this. I'm going to be attempting to monitor the chat, but if a question comes through that's timely and I'm not answering it, feel free to shout them out to me, people who are monitoring the chat. Oops. So I have no financial disclosures, except for the fact that this is like my favorite thing to talk about in medicine of all times. So I'm really excited to talk to you about it. So some objectives for the talk today. We'll examine risk factors for AKI, specifically in patients with cirrhosis. We'll talk about a framework for evaluating AKI in patients with cirrhosis, which is not very different from the framework that you already know for AKI. We'll review the pathophysiology of hepatorenal syndrome. And we'll talk about how estimating kidney function with creatinine could introduce inequity to liver allocation in patients with cirrhosis. And we're going to look at some treatment options for HRS-AKI, and I'll tell you about what that means, and I have some exciting news to share regarding that. So like any good academic half-day talk, I'll start with the case. So this is a kind of combination of a couple patients that I had. He's a 55-year-old man. He has hepatitis C cirrhosis, presenting with 3 days of worsening altered mental status. And I'll just give you like truncated version of what we might talk about in morning report. His past medical history, he has portal hypertension and known duodenitis because of the portal hypertension. His hepatitis C is not treated, and his history of SBP. Medication-wise, he's on spironolactone and furosemide, pantoprazole for his GI bleed, propranolol for the portal hypertension, lactulose and rifaximin for the HE, and trimsulfa for SBP prophylaxis. So like nothing really out of the ordinary. Like this is a pretty like typical medication list that a cirrhosis patient might come in with. Vitals, he's afebrile, his blood pressure is a bit soft, but nothing, again, like not too crazy for a cirrhosis patient. He is like borderline tachypnic, but oxygenating okay on ambient air. And on exam, you note that he's a bit sleepy, but arousable. He has scleral icterus. His belly's pretty taut, and there is fluid wave. His legs are pretty edematous. His jaundice is only oriented to name, and asterisk is present. And then you get some basic labs, or ED gets some basic labs, and these are the labs that you get. You notice that he's quite anemic, and he has this AKI. So freak out, right? I remember presenting him to morning report, and I like got to the creatinine portion, and I like said it was 2.9, and there was like a murmur in the room. Everybody's like, whoa. So I know there's like one thing that we worry about all the time when something like this happens. But if I would really appreciate it if you could just like put it in the chat, like out of all of this, what are some things that make you worried that could be contributing to his AKI, like out of everything on this board? Let's take a couple seconds to kind of put our brains together and think about that. Cool. Blood pressure, sure. Blood loss for sure. Anemia. I think a lot of people are thinking like maybe is this intravascular volume depletion is from anemia. Yeah, a lot of people are thinking maybe not enough effective arterial blood volume. It's definitely decompensated. Anything from his like, okay. Great. Yeah, he's definitely decompensated. I agree with that. He's hella decompensated. Great. Thank you for participating. Let's move on. So when we'll talk about all of this, but to me, all these factors were kind of attributing to why this AKI could be. And I think a lot of people were pointing at, oh, decreased effective arterial blood volume, which I think a lot of it can be that. But we'll see how like untreated hepatitis C can be a cause, or trimsulfa, or just the fact that this person has a lot of ascites. I agree that anemia is definitely a contributing factor. So before we go into that, let's talk about how we estimate kidney function. And this is not specific to patients with cirrhosis, but really for any patient. There's a big discussion in nephrology right now But for now, we've been using creatinine to estimate kidney function, and that's been the surrogate for GFR. But I just kind of wanted to pose this question of like, is creatinine really the best way to estimate kidney function in patients with cirrhosis? Because what is creatinine really affected by? It's affected by your muscle mass. It's affected by your diet and how much protein intake that you have. It's affected by your activity level, whether you like lift a lot or bike a lot or whatever have you, compared to somebody who's more sedentary. And there is data that says the more frail you are, the lower your creatinine is probably affected by all of these. And then if you think about your kind of typical patient with cirrhosis who's sick enough to be admitted to the hospital, they have low muscle mass and they have pretty bad PO intake most of the times. And because of the liver function, they actually have decreased production of urea and creatinine. And they're usually pretty frail too, if they're sick enough to be admitted to the hospital. So then you start thinking like, why are we using creatinine if this is not, if so many factors in patients with cirrhosis is going to be affecting serum creatinine level. So there was this interesting study that was done pretty recently that looks at a lot of actually probably like a dozen different factors of what might affect liver allocation when it comes to transplant between men and women. And I recognize that on its own might be a little like inequity producing because it's not capturing a population that might identify either way or pushing that population into categorizing themselves either way. But this is actually like not just multi-center, but like national study looked at over 80,000 adults with cirrhosis. And it looked at a bunch of different factors, but I'm just going to highlight a couple. So one of the things they looked at was waitlist mortality rate. So like how often are these people dying just on the wait list before they get the liver transplant? And if you don't kind of factor in just like raw data, if you look at it, women are 8.6% more likely to die on the wait list than men. And if you correct for MELD sodium, the mortality rate goes up. So it's 14.4% more likely for women to die. And if you correct for serum creatinine, it also goes up. They're 13.6% more likely to die. So maybe, I don't know, MELD and like serum creatinine is maybe kind of underestimating how sick women are. Another thing that they looked at was the likelihood of these people getting disease donor liver transplant. And again, with the just raw data, women are 14.4% less likely to get DDLT. And then when you correct it for MELD sodium, this is kind of a little confusing. I have to think about it, but the how less likely it is for them to get transplant goes down, meaning men and women who got, if you compare men and women who got transplants, women had to have higher MELD score. And same here for serum creatinine, kind of like this, the disparity goes down. So women who got transplant compared to man had to have higher serum creatinine. And that this begs a question of, I think these two markers that we think a lot about when it comes to liver transplant in cirrhosis patients really underestimate how sick women are. Then what about Cystatin C? Some of you are familiar with this, some of you are not. This is kind of a new thing that people are trying to do to estimate GFR more correctly than creatinine. And for those who are not too familiar with it, as opposed to creatinine that's only created by muscle cells, Cystatin C is actually made by all nucleated cells in the body. And it's, filtered and reabsorbed pretty similarly to creatinine. So people are thinking, and there's a lot of data out there that this might be the more accurate way to estimate GFR. And then there is an equation out there that you can use to estimate GFR. There's CKD-EPI equation from 2021, which is the creatinine version is what UW uses. But there's also a Cystatin C one, and you can just look this up on MD Calc. So the data is pretty readily available. And even within the liver kidney world, there's a movement to kind of close this gap. There's this study that came out last year from Stanford. I know MELD has been redone a couple times, but they came out with MELD 3.0, This doesn't really factor in cystatin C, but it factors in your gender. And I think it uses like a different weigh-in for creatinine based on your gender. And there's also, this is not the only study. There are more studies kind of coming out looking to see like a cystatin C, a better way to kind of estimate for like the mortality rate for patients with cirrhosis. Zainab's commenting that it's expensive. Yes, for now it is. And I've also heard it's a very valid point that it's not available at all institutions. Like, for example, at the VA, I think it's a pain to get. So just moving forward with cystatin C, like nationwide right now, I definitely think it's premature. Because it's going to introduce a whole other set of equities, like, transplant centers who have access to cystatin C versus who don't. That's definitely going to introduce inequity. I don't think we're there yet, but I do think this is something that's in horizon. I think like creatinine as a marker for GFR is probably eventually going to go away. But I just wanted you to keep this in mind, which I thought was because I thought it was interesting. Anna, oh, sorry, Rebecca said, how long does it take a cystatin C to come back? I don't know. That's a great question. If somebody knows, please put it in the chat. Let's see. Any thoughts on using cystatin C alone versus creatinine? I'm not educated enough in this matter to see like which is more like validated. I do think it's still pretty new. All the cystatin C has been getting looked into for a long time. So my short answer is I don't know. So yeah, change is unlikely until like the liver transplant boards really moves away to cystatin C, but there are a lot of factors that are going into this. So I'll kind of stop here and see if people have any questions before we actually go into AKI with cirrhosis. Great. So let's look at reasons for AKI and cirrhosis. Is not very different from how you usually work up AKI and cirrhosis. It goes back to pre-renal, intrarenal, and post-renal. So let's start with our pre-renal, and this is kind of, I think usually what people mean when they say pre-renal is intravascular volume depletion, and cirrhosis patients definitely have multiple reasons to be volume depleted. They're on lactulose, they're pooping a lot, they're on diuretics, they're peeing a lot. They usually don't eat and drink that much if they're sick enough to be in the hospital. And then there's this category of renal venous congestion. And this is something that I didn't really appreciate until about like 2-3 months ago. And we'll talk a little bit more about cirrhotic cardiomyopathy, because that was confusing to me when I first learned about it. That can ultimately lead to hepatorenal syndrome. And more, a concept that I was more familiar with was abdominal compartment syndrome, or just like a lot of ascites kind of pushing on the renal veins and causing congestion and causing AKI that way. And then, of course, the decreased effective arterial blood volume. Hepatorenal syndrome is a big bucket that we'll talk about more, that we worry about the most. And hepatorenal syndrome with a decreased cardiac output can definitely do this too. So how do you suss this out? Kind of like you would for any other kidney injury patient. You look at your microscopy to see if you see any evidence of volume depletion, like hyaline cast. You do thoracentesis to see if that relieves the venous congestion and improves creatinine. You do really good volume assessment, and this includes looking at the IVC with an ultrasound. And then if you have enough evidence to say this person might be intravascular volume down, then you try to give them volume back with albumin. So let's talk a little bit more about cirrhotic cardiomyopathy. So what happens? So you get cirrhosis, you get portal hypertension, which is kind of seems like the cause of all bad things that happen with cirrhosis. And I don't know too much about like exact mechanisms of this, but kind of a hand way of saying this, this causes endothelial dysfunction. and then creates kind of like a chronic inflammatory state with inflammatory cytokines. It's kind of similar to how HRS happens. And then there's bacterial translocation from the gut. So all of this kind of creates the systemic inflammation that causes cardiomyopathy. So I think of this more as like HFpEF physiology than anything else, because a lot of the times you get echo on these patients and they have a normal left ventricular size and ejection fraction. So then this cardiomyopathy decreases the cardiac output and might not be able to compensate physiologically, which can lead to hepatorenal syndrome. So this is just something to be aware of. Patients with cirrhosis can also be also have HFpEF physiology and have renal venous congestion. So let's move on to intrarenal causes. And this is a bucket that kind of gets jumbled in people's brain a lot. So I like to sub-bucket these into glomerular, tubular, and interstitial. So what are some like glomerular pathology that can be specific to patients with cirrhosis? So with this patient, they have untreated hepatitis C, and hepatitis C can cause MPGN. Patients who have hepatitis B, that can be associated with just GN, and cirrhosis patients have also, I think, higher incidence of IgA nephropathy. I think the mechanism is not exactly understood, but it's thought to be like multifactorial. Maybe it's not cleared well enough. Plus maybe the liver is making a lot of like abnormal IgA, but there's something to be aware of. And then tubular pathology that can be specific to cirrhosis patients, toxic acute tubular injury. These patients often have high bilirubin and bile acid circulating in their system, and that can cause kalemic tubular injury. And often these patients end up fluoroquinolones for SVP prophylaxis, and that can cause, fluoroquinolones can also cause tubular injury. And of course, if any pre-renal state is prolonged, that can cause ischemic ATN, and patients with SVP who are pretty sick and that they can develop septic ATN as well. And lastly, interstitial pathology that could be specific to cirrhosis patients is again fluoroquinolones and Bactrim, which a lot of patients, including this patient, ends up on for SVP prophylaxis, and PPIs can also cause an interstitial nephritis. So when you look at a patient with AKI with cirrhosis, there are all these other reasons other than volume, like intravascular volume depletion versus HRS, that could be causing it. And so how do you suss this out? You get a UA, look for blood, you do urine microscopy, you look for a CAS, are there red cells, blood cells, red CAS, white CAS, or like any evidence of kalemic nephropathy. Sometimes you see BOD, I think those are really rare though. And you can also assess for proteinuria for any evidence of glomerular or tubular injury. So lastly, I think this is really rare, but I just wanted to point it out because I thought it was interesting. What's like a post-renal cause that could be specific to patients with cirrhosis? So some patients are on midodrine because maybe they've had kidney injuries before, or they have really low blood pressure, which is an alpha-1 agonist. And the mechanism of this is smooth muscle contraction. And we use it for this effect, right? For vasoconstriction, you increase the MAP and hopefully increase the perfusion. But then what ends up happening is, I guess, theoretically could also lead to sphincter contraction. And then that can cause obstruction and cause post-renal AKI. I don't think this is very common, but something I just wanted to point out. So kind of broadly reviewing everything we talked about, this is a nice graph or graphic that I found in a CJSON review article that came out this year. And also remember, there could be non-cirrhosis related reasons that somebody can have AKI too. Just because they have cirrhosis doesn't mean that these are the only causes that AKI can happen. So that was a lot of information. I'll take a second to see if there are any questions. Oh, hi, Carrie. HRS lover.
I'll just share a joke. I said, I welcome to Kerry, and then he said that he had a sixth sense that HRS was being discussed.
Great. Mac, abdominal compartment syndrome does happen with cirrhosis. Like that's one of the reasons why we worry about like renal venous congestion. Like if you have so much ascites and that's pushing on the renal veins, then by renal vein congestion, that can cause AKI. So I oftentimes like you just do the thora, and of course people are para, and then you do what do you call it? You give them albumin because you did para. So who knows what led to what, but their creatinine improves. Okay. So let's continue with our patient. So he gets submitted. We stop the diuretics like we do for decompensated cirrhosis patients. We transfuse him with red blood cells. And as you guys were worried, I was also worried about GI bleed in this patient. We did do a paracentesis and it was negative for SBP. GI did endoscopy. I just showed known duodenitis, nothing new, and it was just slowly oozing. So they were like, there's really not much we can do. But with our interventions, creatinine downtrended to 1.0, so we were happy, and creatinine was pretty stable above 7 without any transfusion. So you're kind of like teeing him up for discharge, and then he gets worsening anasarca, worsening pulmonary edema, he's requiring oxygen, and then his sodium decides to just trend down to low 120s. His blood pressure is trending down to uncomfortable range, and his creatinine is creeping back up to 2.5 pretty fast this time. And then BUN is also increasing. And then you're noticing that he's getting oliguric as well. His urine output's going down. So you're in this like panic zone again, like what is happening? I got to call nephrology. Like this must be HRS. Like how this patient's really, really sick. Now this is really something that you're worried about, and we're gonna kind of take the rest of the time talking more about HRS. So what is hepatorenal syndrome? This is a definition that I came up with. Okay, so it might be imperfect, but I kind of think of it as a kidney injury that's caused due to decreased effective arterial blood volume from neurohormonal changes induced by liver failure. But the functional integrity of the kidneys are intact. So like if you take the kidneys from these patients who are in HRS and transplant into like a non-cirrhosis patient, then the kidneys would function fine. So the incidence of this, if you look at non-azotemic cirrhosis patients without ascites, in a year, maybe like 18% of patients develop it. And then in 5 years, maybe 39% of the patients develop it. And we're familiar with this term HRS type 1 and HRS type 2, but we're moving away from these terms and saying it's HRS-AKI and HRS-CKD. I think that captures what we're thinking about and worried about more accurately. So why do we care about HRS? So it turns out the mortality once you develop HRS, especially HRS-AKI, is very, very high. So if you look at this graph, the x-axis is time and the y-axis is probability of life. So 1 is life, 0 is death, and or like no probability of, is that what it is? Yeah. So this line is cirrhosis with ascites without HRS, and this dotted line is people who develop HRS CKD. So definitely dips down more than people who don't have HRS. But if you look at this HRS-AKI curve, it does not look good. Like the prognosis beyond 3 months is essentially nil. So this is why recognizing HRS-AKI early and intervening early is really, really important. So this is how I think about it in my brain. Kind of, it will go over the pathophysiology a little bit. So you have a heart that pumps out blood to your, this is a graphic of a gut, but really like this is supposed to be splanchnic circulation. And then whatever gets absorbed here goes to the liver, and then it goes to the heart, right? And then the heart also sends blood to the kidneys, and then it goes back to the heart. So this is the portal circulation. This is the splanchnic circulation. So when you have cirrhosis, you develop portal hypertension, right? This all gets congested, and you end up, the liver ends up releasing a lot of nitric oxide, which then leads to splanchnic vasodilation. And not just splanchnic vasodilation, but it also leads to a decrease in systemic vascular resistance, meaning that there might be enough blood in the vessels, but it might not be moving as much because the resistance is down and you might not have enough pressure. So this leads to then decreased effective arterial blood volume. I always like to say, like, kidneys are very myopic, like they can only see what's in front of them. So even if they have enough blood in front of them, if it's not like moving, they don't think there's enough blood there. Other things that is contributing to this is a lot of people with decompensated cirrhosis has high bilirubin, and again, bile acids kind of circulating around their system, and that's also inflammatory. So that contributes to decrease in systemic vascular resistance. And then there's, again, bacteria translocation that causes kind of systemic inflammatory response, and that also decreases systemic vascular resistance. So, and this is kind of like the hepatorenal physiology. Like, I think to a certain degree, a lot of patients with cirrhosis has this. So your body just try to compensate for this decreased systemic vascular resistance. So I'm just going to focus on this part of the body for a bit now. So how does a kidney try to compensate for this? So it increases, the body tries to increase the sympathetic tone, and then the kidneys activate ADH activation, and then RAS activation. So what do these lead to? So ADH will increase water reabsorption. So remember, body always, volume trumps tonicity. So even if you're getting very hyponatremic, your body will just rather have volume. And RAS activation leads to sodium reabsorption in the kidneys, hoping that water will follow the sodium. And then there's increased cardiac output, but as we talked about earlier, if somebody has cirrhotic cardiomyopathy, they might not be able to compensate very well with cardiac output. But either ways, these are the ways that our bodies like really try to compensate and increase perfusion. So kind of putting this all together, and this is actually from Dr. Payne's slide, you get cirrhosis, you get systemic vasodilation that leads to decrease in systemic vascular resistance, that decreases effective arterial blood volume, and our body tries to compensate by retaining water, retaining sodium, increasing systemic vascular resistance by increasing sympathetic tone, and increasing cardiac output. So these are all like kind of reasonable compensatory mechanisms to maintain perfusion. But then these things happen that throw a wrench into the plan: infection, bleeding, cirrhotic cardiomyopathy that doesn't allow cardiac output to go up, progression of liver disease, and renal vasoconstriction. And that kind of throws a wrench into this like very kind of fragile system and doesn't allow the body to maintain perfusion. And then that's how you get kidney failure, and that's how it leads to HRS-AKI. That was a lot. What questions do people have? Great. I hope that means I'm not, it means I'm not going too fast. Okay, so we talked a lot about how does HRS happen. So now let's talk about how do we diagnose HRS-AKI, this thing that is going to kill people very fast. So there's a criteria that we talk about a lot, right? So people need to have advanced liver failure and have portal hypertension, because that's really the cause of everything. And they need to have acute kidney injury to have something with the title acute kidney injury. And there has to be no other like very apparent reason to cause AKI. So kind of going back to the beginning of the talk, a lot of other things that could be causing AKI. Not everything has to be ruled out, but just like very apparent things have to be ruled out. And then if you don't improve with volume expansion, and this is kind of part of ruling out any other apparent causes of AKI, such as volume depletion. And we usually do this with albumin challenge. And then there are other considerations that are not really in the criteria, but I've heard nephrology say these are kind of like telltale signs that somebody might have HRS-AKI. And one is azotemia. If somebody has increased BUN, this happens with any kind of pretty severe pre-renal state, right? So body's just trying to increase its osmolality, so reabsorbing the BUN. And hyponatremia, this happens because ADH is activated and you're pulling in more water into the system. And the result of this is your urine osm, sorry, that's misspelled. Urine osm is going to be high because urine is going to be very concentrated. And then because RAS is on, you're going to have low urine sodium. So for example, and then this meaning like undetectable, like below 10. So I've seen folks become like less concerned about HRS-AKI if somebody's not on diuretics and their urine sodium's like 30, for example. That's less concerning. And essentially all these 4 reasons are just like looking for evidence of renal hypoperfusion. Okay, so how do we manage HRS-AKI? So goal of anything that we do for these patients is really to improve renal perfusion. In an acute care setting, we give them albumin to increase the EABV. And then we often start them with midodrine. We talked about this, alpha agonist that will cause vasoconstriction and increase the MAP. And then octreotide, which is somatostatin analog, and it inhibits vasodilation. And then in an ICU setting, somebody's sick enough to be in the ICU, we still give them albumin to volume expand and then start them on norepi, which is alpha and beta agonist. And kind of similarly, it'll increase the MAP and increase the perfusion. And of course, if what we're doing on acute care is not working, the patients are transferred to ICU for norepi. So there's this, I initially titled this new kid on the block, and I realized it's actually not that new because Europe has been using this for years now. FDA finally approved terlipressin, and for those of you who don't know terlipressin, we'll talk about this a little more. I don't know the details of the drama and the saga of this, but it's been multiple trials of trying to get terlipressin approved in the FDA at the FDA. And it finally happened literally a month ago. So this is really exciting. So what is terlipressin? It's a vasopressin analog. So similarly, it increases its MAP. So the goal is to improve renal perfusion. The huge benefit of this is you can do this on acute care. So it's IV bolus. It's not a drip. It doesn't need as frequent monitoring. So you can do this on acute floor. It does seem to have more adverse events than norepi, and maybe Dr. Payne can talk more about this because I know he's written some pieces about this, but it seems like maybe there's especially more incidences pulmonary edema that happens with it that could be independent of how much albumin the people have gotten. But this is a graph that I made up after reading a few articles. If you look at midodrine octreotide, if you say that the rate of HRS reversal, meaning kidney function back to normal, is about yay high, terlipressin is definitely better than midodrine octreotide. And it's norepi is not inferior to terlipressin. So if it has a similar efficacy of norepi, it's better than midodrine octreotide, and if you can give it in acute care, it just kind of seems like slam dunk, right? Like, why aren't we using this? And it's finally approved, and I heard that UW's trying to get it. It's not quite here yet, but at least Dr. Biggins from hepatology told me that once it's here, midodrine octreotide might just completely go away. So kind of going back to this graphic, this is kind of what we know of how to treat HRS-AKI, but terlipressin is probably going to replace this, which is very exciting because it's going to really improve outcome even in acute care setting, and people don't have to be transferred to the ICU. I know there are some trials of seeing, can we do norepi on acute care? I think that's kind of a different thing for a different time, but something to think about, and then think about, you know, what's the future of HRS-AKI treatment. But remember that this is really management of HRS-AKI. And treatment of HRS-AKI is really liver transplant. This is the only way that people are going to come out of this world of hurt. And we use TIPS and dialysis to kind of bridge patients over to liver transplant. So this is kind of how I think about managing and treating HRS-AKI. So some key takeaways: cirrhosis patients have multiple risk factors to develop AKI. So it's important to keep broad differentials when evaluating AKI in cirrhosis patients. Patients with HRS carry higher mortality rate, so it's important to recognize HRS fast. And we talked about how Cystatin C estimates GFR more accurately. It's not really widely used, that it's not widely available yet. So we're not quite there just yet. And terlipressin is a favorable alternative to midodrine and octreotide, and it's comparable to norepinephrine, and it's coming to us soon, which is very exciting. Here are my references. And thank you so much for your attention. We can talk about questions and any concerns.
Lily, there were a few questions in the chat that I just wanted to call back to. So one was from Terrence. For patients who have a partial response to albumin challenge, like initial improvement or stabilization for a few days, but then progression of AKI, how does that factor in the diagnostic criteria?
That's really interesting. I've also seen this before. I think this is when ideally nephrology is already involved and they can kind of help you suss that out. I think there's a criteria for like how much they need to improve. Like sometimes they improve a little bit and then they don't improve like enough for them to kind of prove that their AKI was all from volume depletion. And sometimes people have like overlying ATN. So sometimes you're like, did they not improve because they have HRS, or did they not improve because they have ATN? So then urine microscopy kind of comes in again, right? And if they're like granular casts, and you kind of have your answer that it might be ATN. But if not, then again, you got to look at urine sodium, urine osm, their serum sodium, what's their blood pressure doing, and what does nephrology think?
Awesome, thank you. And there's another question from Lauren, curious of nitric oxide inhibitors, curious of if nitric oxide inhibitors have been studied specifically for HRS, like methylene blue.
I don't know. Carrie says no.
No.
Yeah,
Okay.
I don't know.
It looks like there's a question about droxidopa too, but Carrie also said droxidopa also hasn't been studied.
I've seen it be used, but I'm not familiar with it very much.
You don't need my help here, Lily, but you're right. It hasn't been studied, and we've used it. Actually, we started using it when there was an octreotide shortage, and we didn't have so many other things to reach for. But if you see us using droxidopa, it's definitely a data-free area. That was so awesome.
Thanks, Carrie. Thanks for being
I'm biased. Here. I'm biased because it's also my favorite thing to talk about. So.
Yeah, I want to call out a couple other things in the chat. I agree with Helen that Lily, you make kidneys less scary for me. I agree with that. The goat of kidneys. And I think Carrie said he's gonna have to steal one of your slides that you that he thought looked better than than his. There are a couple other things earlier on in the chat. I think there's the question about how long Cystatin C takes to come back. And I think looking at our lab catalog, and Carrie also shared like 2 to 5 days, I think could be the turnaround time. So maybe not for day-to-day use, but could be used in like, other settings. Like I think Carrie, you mentioned the transplant list. And then, yeah, some comments about the Real Housewives of HRS therapies, but not sure which version. All right. Any other questions before we take a break? All right. Let's take a break here and we will come back together. Let's see, let's come back together at 9:55. So 10-minute break here. Lily, thank you. That was amazing. And we'll have Gina Lenti coming up next at 9:55. So see y'all soon. Get some more coffee or tea or whatever you need to do.